This is a presentation on patient-centered care in the clinical setting, a snapshot of Jane Doe's experience. The Institute of Medicine defines patient-centered care as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. As a registered nurse, my definition of patient-centered care is in very close alignment to that of the Institute of Medicine's. In my nursing practice on a medical telemetry floor, I find that care is best delivered and patient outcomes are improved when I work in a collective relationship with my patients and colleagues. This dynamic within a clinical setting requires a framework to build on. As discussed in Microsystems in Healthcare Part 3, the planning of patient-centered services is based on knowledge of 1. The needs of the major subpopulations of patients served by a clinical microsystem, and 2. How the people in the microsystem interact with one another and with their processes to produce critical outcomes. This knowledge comes from both formal analysis and from tactic knowledge of the practice structure, its patients and its processes, and its daily patterns of work and interaction. As an RN striving to practice in a healthcare-based microsystem, which values providing patient-centered care, I need to be asking myself questions such as, who are my patients and how can I best serve them? Who's on the collaborative healthcare team that I am part of? How do the processes of the microsystem that I am working within function? And how can I use these processes to best serve my patients? What do the long-term results of these patient care outcomes have, not only for the patient, but for the financial prosperity of the system? In short, these conceptual questions are coined as knowing the 4 Ps. Know your patients, know your people, your processes, and lastly, know your patterns. I will tell you how knowing the 4 Ps provided the necessary framework to deliver patient-centered care for a complex patient we will refer to as Jane Doe. Jane Doe was a 33-year-old female admitted to the medical telemetry unit with a diagnosis of cellulitis to the right eye. She was admitted through the emergency department, intoxicated on alcohol and various narcotics. Jane Doe had 2 large abscesses above her right eye, making it impossible for her to see. This patient was a known IV drug abuser in the system and had multiple previous admissions for alcohol and drug withdrawal. The multidisciplinary healthcare team consisted of the attending physician, nursing staff, including wound care, dietary, and case management. The anticipated health outcome for this patient was to have a positive response to the intravenous antibiotic course and a safe detoxification from the patient's narcotic drug addiction. These anticipated health outcomes would be evidenced by the resolution or decrease in the signs and symptoms of cellulitis, as well as a decrease in the adverse manifestations of physiological and emotional withdrawal symptoms from her drug addiction. In short, the goal was to address her infection and assist in safe detoxification while maintaining a safe environment for everybody. Additionally, it was anticipated that the knowledge deficit of self-care and patient compliance, thereby contributing to the patient's current physical state, would be rectified with education and the provision of proper social services. She had a private room during her stay at the hospital. Jane Doe was given a 7-day course of 3 types of intravenous antibiotics and would receive IV lorazepam every 2 hours as needed to manage critical withdrawal symptoms. The patient was provided with a menu where she was able to select her preferred food choices within the diet ordered by the physician and nutritionist. During the 7-day hospital stay, a birthday card was signed by the unit staff and delivered with a flower on the day of the patient's birthday. On a particularly rough day, the patient requested that treatment be postponed until she had a special visit from her dog. Staff was able to accommodate this request, as we saw she needed a special emotional deposit and connection from her outside world before she could continue the rigorous agenda of medication administration and dressing changes that we had determined necessary for her. On the 2nd day of Jane's stay, after having an emotional breakdown, the patient requested that her food trays from breakfast be left in the room until lunch was served, because she was, quote, afraid food was not going to come anymore, end quote. Through sobs, she stated, "I've been on the streets, you know, and I have PTSD regarding when I'm going to eat next," end quote. Although it's usually against the norm to leave food trays in the room throughout the day, staff was able to meet her emotional needs. This adjustment that we made mirrored dignity and respect to Jane Doe, a pillar of patient-centered care. In addition, her dignity was respected when it was determined that male nursing and support staff would relinquish her care when possible. This decision was made after observing a negative reaction she had with a male patient care technician. Jane and I spoke openly about her discomfort with male staff due to past trauma from her childhood. The information obtained from that conversation was shared with the healthcare team. Sharing of information illustrates yet another core concept of patient-centered care. Through having a caring discussion with this patient, I was able to obtain information that I could then share with the healthcare team, and collectively we were able to make adjustments to how and who delivered her patient care. Actively engaged in this patient's care, we as a multidisciplinary healthcare team found innovative ways to keep her participating and open to receiving the medical care she necessitated. Flexing together, two-way participation was achieved in meeting the needs of the patient and providing a tailored plan of care. This scenario that I've shared exemplifies the 4 concepts of patient-centered care: dignity and respect, information sharing, participation, and collaboration. The examples of providing Jane Doe with a private room, allowing her to select her preferred foods, giving emotional support with the birthday card and the pet visit, all of these exemplifies ways that we provided dignity and respect to the patient and valued what she valued. When we flexed together as a healthcare team and shared information about Jane Doe's team that was vital to the progression of her treatment, again, we exemplified another concept of patient-centered care. All of this is an example of participation and collaboration, especially when we were able to keep Jane Doe engaged in her course of treatment and finish the plan of care to a successful discharge. What I learned from this clinical experience with Jane Doe was that patient care needs to be individualized. There's an old adage that there is more than one way to skin a cat. This is true in patient care as well. In order to achieve an optimal outcome, we had to tailor our efforts to meet the needs of the patient. This included being aware and sensitive to the gender of support staff involved in her case, as well as pausing treatment to allow visitation from her pet. Later, she shared with me that she had been planning on leaving against medical advice, but seeing her dog calmed her down enough to stay the course. Knowledge of clinical systems I was working within allowed me to know the pet visitation policy our hospital had, and empowered me to utilize that process as a resource for delivering patient care and support. At a low in our patient's hospital stay, she had cursed out our patient tech and left the hospital unit without communicating intention of where she was going or what she was doing. I was able to reach out to security team as well as case management for assistance while I contacted the attending physician. Security was able to provide assistance in keeping her safe while she walked around the hospital grounds, and case management served as a liaison with the behavioral health facility we send consultations to. Despite providing excellent care to Jane Doe during this hospital admission, there are areas that we could have improved upon. Suggestions for improvement include the following: behavioral health consultations to be placed prior to adverse events. The rationale for this is that early delivery of mental health intervention in collaboration with medical interventions yields better outcomes for the patient. 2. Spiritual and pastoral consultations to be placed during hospital admissions. This rationale is that the rationale for this being that patients of faith who are actively engaged with members of their faith system have an increased sense of support and emotional well-being. Jane Doe was an active Catholic who could have benefited from the consultation if one had been placed. Third area for improvement is the thorough review of history, which would have revealed past negative interaction with male staff during the hospital stay. This intervention prior to an adverse event would have yielded a better outcome for the patient and staff involved. The fourth is that in this instance, the patient's home medication list was not properly documented at the time of admission. There was a delay in administering Jane's psychiatric medication. Thorough patient intake and proper patient assessment as well as documentation allows for a seamless administration of medication, which is critical, especially in complex patient care scenarios. Simply put, improvement in Jane Doe's care would yield better patient outcomes, as well as protection to personnel. Jane Doe came to my unit needing an aggressive course of antibiotic therapy due to a subcutaneous skin infection. She was a known drug abuser with an extensive psychiatric history. The medical team was able to stay on course, providing her with the care she needed by integrating a patient-centered care model of practice. With minimal interruptions, Jane Doe remained compliant to the treatment course. Her care was personalized, relationships were built, and collaboration took place. This dynamic delivery of care allowed open communication and two-way participation from the patient and the healthcare team. We were able to meet the challenges of her complex medical needs while delivering a plan of care that incorporated what she valued and kept her personal dignity intact. In summary, Jane Doe received patient-centered care, which yielded optimal health outcomes, increased patient compliance, obvious personalized care. This took dynamic collaboration between the healthcare team and the patient, as well as open and respectful communication. The thread that tied this all together was that the healthcare team took a holistic approach to achieving our goal when treating Jane Doe. The references utilized to produce this presentation are as follows on this last slide. Thank you very much.